For lung summary, do know the terms dyspnea, tachypnea, pneumonia, pleural effusion, pneumothorax, atelectasis. Dyspnea means difficulty breathing or shortness of breath. Tachypnea, you know the word tachometer, that's the equipment that shows how fast your car going. That's the fast breathing. Obviously, all of us know the word pneumonia. Pneumonia is actually an inflammation of the lung, and because it's such a common cause of death, rest assured that you're going to see it on NCLEX at the latest, but your classes will commonly discuss pneumonia when you hit core. How do patients with pneumonia present? They have fever, they have tachypnea, fast breathing, they have dyspnea, difficulty breathing, shortness of breath, and they do have chills. Chills is what happens to you when you have bacteria in blood, and that's shivering. Pleural effusion is too much, a collection of too much fluid in the pleural space. Let me review pleural space with you. So you remember the lungs. We have two lungs on the left and on the right. You know that the lung has a covering which is made up of two membranes. So the first membrane sits directly on and touching the the lining of the lung, and the second membrane sits separated from it, from the layer one that I drew. So this is layer one, this is layer two. These layers have a name. Layer one is called visceral pleura, and layer two is called parietal pleura. In between these two layers, you have fluid, and that's pleural fluid. So pleura is the double membrane that envelopes the lung. Why is it important? If we have too much fluid in the pleural space, it's going to compress the lung, and you would have to take that extraneous fluid, excess fluid out, and I showed you the picture in class. Now, what if instead of, and by the way, please go back to your anatomy of the heart and remember that epicardium is the same thing as your visceral pleura. It's also got a very similar name, visceral serous pericardium. And the parietal pleura is continuous with parietal serous pericardium. That's why stretching one affects the other. If a person has an inflammation in one, the pleura, heart may be affected. If the patient has, for example, an inflammation of the pericardium, patient may feel as if there is a shortness of breath. Now, let's differentiate it from pneumothorax. If instead of fluid in the pleural space, we have air, collection of air, and I'm drawing it in pink, then we call it pneumothorax. Thorax is chest, pneumo is air. So if there is a collection of air in the pleural space, that's when we say patient has pneumothorax. Obviously, if there is sufficient air, what that air is going to do is drive the lung. The lung is going to collapse, and so you will not hear any breath sounds. Now, do differentiate the term pneumothorax from the term atelectasis. Pneumothorax is what I just described, air in the pleural space. Atelectasis, let me break it down for you. A means no, tele is end, and ectasis is a word for dilation. So there is no end dilation, meaning that there is no dilation of the air sacs, the alveoli. There is a collapse of the air sacs, the alveoli. Thus, the air sacs don't have any gas in them, and the gas exchange via the alveolar membrane is not possible. Obviously, when you breathe in, you add fresh oxygen to the alveoli and breathe out carbon dioxide that was delivered from the tissues. When alveoli collapse, when you have atelectasis, that action is not possible. All right, now let me go over a few causes of pneumonia. Let me start off by discussing Staph aureus, Staphylococcus aureus, or Staph aureus. You absolutely do need to know this bug, and you probably did study it very well in your microbiology classes. Do know that it lives on skin of about a third of the population. It colonizes skin, and colonize means it lives on skin without causing disease in a patient. But sometimes it does cause disease, and when it does, it's extremely virulent. And I actually mentioned it in cardiology videos that it causes damage to valves, and it can damage any valves that it comes in contact with, whether those valves were previously damaged or not. So it's very virulent, and some of these species some of its subtypes are very resistant to antibiotics. For example, MRSA and VRSA, vancomycin-resistant Staph aureus for VRSA, and methicillin-resistant Staph aureus for MRSA are very difficult to treat. All right, now let's go over bugs that are commonly seen as causes of pneumonia, and actually are very easy to remember because they have pneumonia in their names, meaning that they cause pneumonia. Notice that E at the end, so it's not pneumonia, it's pneumoniae, and different pronunciations. So pneumonia, streptococcus, not staphylococcus. It's a coccus, but it's a streptococcus in chains, is the most common cause of pneumonia in a non-medical setting. So not in the hospitals, not in places where patients present with various and go to with various diseases. Another name for this kind of a pneumonia is a community-acquired pneumonia, CAP or CAP. Mycoplasma pneumonia causes pneumonia that is a kind of unique in the sense that you have a patient who is not feeling quite himself or herself, goes to a physician, kind of walks into the office, and has very mild symptoms, mild enough to continue their normal daily regimen, normal daily activities. But when you look at the x-ray, you see severe pneumonia. And when you see that x-ray, the pneumonia distribution is interstitial between the alveoli, and we call this pneumonia atypical because patient is not coughing up a lot, patient does not feel extremely bad, and patient's symptoms start very slowly. Because the patient kind of walks into the office versus is feeling so bad that he or she can't do anything, we call it also walking pneumonia. So this mycoplasma pneumonia causes atypical / interstitial / walking pneumonia, and these three terms are used interchangeably. And the population that it affects are younger adults between 18 and 40 years of age. These may be very normally healthy individuals, military recruits, college students who live very close together. Now, strep pneumo affects adults and usually older adults. In children, number one cause of pneumonia is a virus. It's called respiratory syncytial virus, RSV. Another virus, VZV, varicella zoster virus, normally causes chickenpox. In the worst case, in kids. In the worst case scenario, it may progress past fever and rash to pneumonia. And varicella zoster virus, after kids recover, varicella zoster virus lies dormant in their ganglia and reactivates if patient's immunity drops when they get older and present as a rash in the distribution of that nerve, and you've studied this in your anatomy class, and it presents as a belt-like rash in the area that is supplied by that nerve, and because that area is belt-like, we call it shingles. Now, while strep pneumo and mycoplasma pneumonia are a giveaway as to what they do, Haemophilus influenzae is actually a misnomer. Haemophilus influenzae is a bacterium that does not cause influenza. Haemophilus influenzae does not cause influenza. Influenza, another name flu, is actually caused by the influenza virus. Let me say it again. Influenza virus causes flu, the influenza, and Haemophilus influenzae does not cause flu. So what does it cause? It's a bacterium that causes pneumonia, among others, and it causes inflammation of the ear, otitis, itis of the ear, otitis media. So basically, it nowadays in 2022 causes inflammation of the mucosal membranes because it takes the IgA, immunoglobulin A, something that I talked about in immunology section when I was talking about Peyer's patches. IgA is secreted in tears, it's secreted in other fluids such as breast milk, and protects the mucosal surfaces. What Haemophilus influenzae does, it breaks up the IgA, it has IgA protease, it digests IgA. IgA is no longer functional, and so mucosal infections are caused. Before the advent of a working vaccine, Haemophilus influenzae used to be the third most common cause of inflammation of the meninges, the membranes that cover the brain and the spinal cord, the central nervous system. We call it meningitis. And the most common cause of epiglottitis. So let me go over the two. Meningitis is an inflammation of the meninges, and when we suspect meningitis, unless there is an elevated blood pressure, what we do is do a lumbar puncture and treat right away. So we also do a physical exam. So we try to flex in the neck, and if a patient is resisting that flexion in the neck, resisting the bending of the neck, we call that sign positive Brodzinski sign. When a patient is lying on the back, when you try, so with knees bent, with feet atop of the table, when you try to straighten up the knees, the leg in the knees, we call it extension of the knees. Knees are spelled with a K. So if you are unable to extend the knees, we call it a Kernig sign. So Brodzinski, you can't flex the neck, you can't bend with a B the neck. Kernig, you can't extend in the knee. Knee starts with a K. So these are two physical exam findings, which are, we say, positive if there is a resistance on the part of the patient. Why does the patient do that? Because meninges are inflamed. Patient doesn't want you to stretch them even more by either flexing the neck or extending in the knees. Don't forget that patients with meningitis and other bacterial infection often have very high fever, and a random factoid that they started asking recently on NCLEX is what causes excuse me, what causes fever. And you do need to know that interleukin 1, IL-1, is a cytokine that is a known pyrogen, generates fire, generates fever. Now let's go over epiglottis inflammation. itis of the epiglottis, epiglottitis. What is epiglottis? It's a flap of tissue on top of the trachea that closes when you're swallowing. If that flap of the tissue is swollen, you can't swallow and you can't breathe. Trachea is going to be closed and patient suffocates because you can't inhale, and that is a medical emergency. Another way you may have problems with epiglottis would be airway spasms due to a bug called Clostridium tetani, which causes tetanus. And tetanus is a disease where muscle spasms and contractions are seen. For example, we see a so-called locked jaw where a patient with tetanus is unable to open the mouth. All right, now let me briefly mention viruses that cause common cold. Rhinovirus, rhino means nose, rhinovirus, and adenovirus, adeno means gland. Adenovirus are two viral types, but coronavirus, something that everybody knows. So rhinovirus, coronavirus, and adenovirus were known forever to cause common cold. A particular variant of coronavirus, there are quite a few variants. One of them, COVID-19, may cause lung complications such as pneumonia. Don't forget the signs and symptoms of pneumonia: fever, tachypnea, fast breathing, dyspnea, difficulty breathing, and chills. And only in the very, very, very severe cases does it cause ARDS. All right, now let's talk about chronic obstructive pulmonary disease, COPD. There are two types of COPD. One is emphysema, the other one is chronic bronchitis. Let me start off talking about chronic bronchitis, itis of the bronchi. Bronchi are the large airways, all right? Trachea, and then right after trachea, we have bronchi. The right main stem bronchus, left main stem bronchus. So we have an inflammation of bronchi here. What does chronic mean? We have defined chronic in terms of months, literally. So it's 3 or more months per year. A patient who has productive cough, productive meaning producing mucus, a lot of mucus, for 3 or more months per year for the duration of 2 years or more. So quite a chronic state. And this is due to an inflammation of the bronchi, bronchitis, where a mucosa that lines the airway from the inside, mucosa, undergoes hyperplasia, increase of cell number, and these cells produce copious mucus, a lot of mucus, and so patients have a lot of discharge. Now this mucus obviously clogs up the airways. There is a passage constriction. If you were to hear, if you were to try to listen to the sounds, auscultate sounds produced that a patient with chronic bronchitis has, you're going to hear wheezing, and moreover, you're going to hear snoring-like sounds, and we call them rhonchi. So just make that association. Bronchi, you hear rhonchi in bronchi. Just get rid of that B. You hear rhonchi in bronchi. Now, do not mistake chronic bronchitis for acute bronchitis. Acute bronchitis is usually viral, and you may or may not do a sputum culture depending on the situation. And if you do, obviously you need to analyze it and confirm that it is not a bacterial sputum that you're talking about. The second type, so this was chronic bronchitis, the second type of COPD is emphysema. In emphysema, you have a destruction of tissue in the alveolar sacs. Alveoli are sac-like dilations which are at the end of the respiratory airways, and they have walls that separate them. In emphysema, what we have is the destruction of the respiratory airway walls. This results in air trapping because instead of having multiple little sacs, we now have a huge air sac that is like a balloon that was inflated for a long time and now has been deflated. So it's very flaccid. Patients who have emphysema can easily be recognized as barrel-chested patients. They have an increased chest diameter. All right, so I just spoke about COPD. COPD would be chronic bronchitis and emphysema, and COPD stands for chronic obstructive pulmonary disease. Obstructive is actually in the name. There are in total 4 obstructive diseases. As I mentioned, 2 of them are COPD. So chronic bronchitis, emphysema, and asthma is the third one. Do note that chronic bronchitis and emphysema fall under the umbrella of COPD. Asthma does not. Asthma is a third obstructive disease. There is a fourth one, you don't need to know that. But when you talk about asthma, you do need to realize that patients with asthma are unable to breathe well. They have difficulty breathing. Normally, a patient breathes with the help of only the diaphragm. So a patient who is hungry for air not only has an increased respiratory rate of more than 16, patients actually utilize every possible way to breathe at all. And so patients utilize other muscles. We call them accessory muscles of respiration. Those are the neck muscles. Those are the muscles between the ribs, the accessory muscles of respiration. Nasal flaring is also seen in those patients. Patients are not getting enough air. They're going to do anything to get that air in. And we want to help those patients, want to dilate their bronchi, and we use medications called bronchodilators. Just for your pharmacology courses, those are beta 2 agonists, and they relax the muscles of the bronchi, and that's why they're called bronchodilators. Beta 2 agonists, bronchodilators can save life when patient has an asthma attack. Given immediately and act immediately. Now, we were just now talking about obstructive lung diseases. I want you to think about obstructive lung disease in general, like you would about a balloon that is very easy to inflate and becomes very large very easily. And when you deflate it, it kind of becomes very flaccid, and even when you completely deflate it, it's a little bit larger than you started off with. And you've all seen those kind of balloons. Now think about, and let's call it balloon A, okay? And that would be obstructive, or let's call it balloon O for obstructive. Now let's talk about balloon R for restrictive lung disease. What we want to think about here is a balloon which is so elastic, so springy, that as much as you try to inflate it, it's extremely difficult. You literally need, you can't do it with your mouth. You actually really need that equipment. That's the type of a balloon I'm talking about. Let's call it balloon R. Okay, so R and O are obviously very different. R is very difficult to inflate. In a human body, we do have pathological situations where we see that situation where a patient's lung is very difficult to expand. Lung expansion is very difficult due to usually due to scarring and other material that is found between the alveoli, between the respiratory airways. And so lungs kind of pull together. They're very springy, and they are very, very difficult to expand. Not only that, as soon as you expand them, they fall back to their initial shape. We call those disorders restrictive respiratory disorders or restrictive respiratory diseases. As I mentioned, they're very, very difficult in terms of expanding the lung. What causes them, among others, worldwide definitely true, very untrue for the US. We don't have a lot of tuberculosis here. We don't even get vaccinated for tuberculosis here. But worldwide, tuberculosis is a very, very severe condition caused by Mycobacterium tuberculosis, a bacterium. And these bacteria are very difficult to treat, and we need a lot of different, we need to use multiple antibiotics, so it's a multi-drug resistant bacterial condition. And if untreated, what it forms are nodules, and nodules are called tubercles, and these nodules are formed in the lungs and throughout the body. And once again, they can be treated, but treatment is very difficult, and those bacteria are called multi-drug resistant. So think about obstructive versus restrictive disorders. Restrictive lung disorders are essentially scarring. Obstructive lung disorders are essentially flaccid lungs, or lungs that don't get enough oxygen.